call their physician and is able to get next day visits. They're able to spend up to an hour or even more.
So what are you talked about some of the risk factors. What are some environmental factors or things that preventative things that people can do to help to preserve their fertility?
Yeah, great question. So, I mean, I think, healthy lifestyle, very important as well too. The diet, there's a lot of inflammation nowadays because of the typical American diet, right? So eating a balanced diet is going to be very important, avoiding a lot of processed food, ensuring that you get your 5 servings of fruits and vegetables. It's interesting, I say that to almost everybody that I see for an infertility consultation. 5 servings of fruits and vegetables. I also get a BMI from our patients whenever I see them, just talking about the benefits of incorporating exercise as well to maintain a healthy body weight as they go through this process of fertility, or even in those who are just trying to start the process of trying to get pregnant. Avoidances, very important. Reproductive toxins. So, tobacco. So I haven't actually talked about the effect of tobacco. So we know that cigarette smoking, interestingly, can actually cause an increase in the rate of attrition of the egg count in a woman's ovaries. So women that smoke actually go through menopause a few years earlier than women that do not smoke. And we think it's because of that effect of tobacco smoking in increasing the rate at which they lose eggs in their ovaries. So it's something that can be, that patients should avoid, certainly both male and female. We also think it could introduce, an increased rate of DNA damage essentially in their gametes because, it's a toxic thing for them to ingest at that point in time. Other drug use, certainly for the men, marijuana is a big one. Now, there are also other things in in the environment, I'm sure you've heard of this term, endocrine disruptors. So it's a very big label out there, and lots of studies have looked into that. A big one is BPA that goes into some of the plastics that we make. So avoiding microwaving food in plastic because you just don't know if it's got BPA in it. Other things that most of the other things that we expose to in the environment, we just don't have any control, right? We just don't have any control. But the things that we have control on are the things that we put in our bodies. So avoiding that, trying to eat a healthy, balanced diet, getting the right amount of fruits and vegetables. If you're trying to get pregnant, getting those prenatal vitamins, trying to maintain a healthy body weight, trying to reduce stress, get enough sleep. Those are things that are incredibly important in helping the process go along smoothly.
Yeah. That's great stuff. Great stuff. So let's say a patient is seeking care from a reproductive endocrinologist. What does that kind of look like? Can you talk about the process and what happens when they get to you?
Yes. So seeking care now, I mean, I know access is tricky because there are not nearly enough reproductive endocrinologists. I mean, last I checked, I think probably 1,800 in the United States, not that many. So, and, funny enough, we tend to be concentrated in large metro areas, but then what about the other places? So patients have access issues. I think some of the things that we're doing right now to improve access is offering telehealth services in all our different practices so that patients that live even just a little further away can have access that way. So in preparing for that visit, I like to say do the best that you can, but I see a lot of patients who have not had any testing, and that's okay because I could do all the testing that you need. So I think just getting in there, meet with your gynecologist, get the referral if you need that referral for insurance purposes. If you're lucky, you don't need the insurance, you don't need the referral, then seeking the closest reproductive endocrinologist that you can get to and trying to get in, even if it's via telemedicine, because I always say that the initial consultation is just trying to get to know you, which can be done easily virtually. We don't have to do an ultrasound. We don't have to do any blood work. We don't have to do anything during that initial consultation. We can just have a conversation, really try to get to know you as the patient. And then at that point in time, then discuss the evaluation that needs to occur down the line, which can be done in 1 or 2 days. and then you can follow up with your reproductive endocrinologist, talk about the results, and then move on into a treatment plan. So I think, just knowing exactly what you want as a patient when you come into that visit, and hopefully your reproductive endocrinologist can take it from there and guide you in that journey towards parenthood.
Yeah. So we talked a lot about your role in fertility. Can you kind of just explain to the audience what a reproductive endocrinologist does? What does your field entail?
Wow, it's always a very tricky one to describe, because I think majority of what reproductive endocrinologists do is infertility care, and that's just because infertility is so common. 1 in 6 couples struggle with infertility, not to mention, same-sex couples that require specific gamete, right? So it's really, there's so many, most of our days are spent taking care of patients who have infertility. But a reproductive endocrinologist generally is, as 4 years of medical school, then we do 4 years of an OBGYN residency training, and then 3 years of a subspecialty training in reproductive endocrinology. The field is interesting because technically anything, any endocrinological issue that can affect reproduction is something that a reproductive endocrinologist can manage. Okay. So, and then we also have some surgery involved in what we do as well, too. So reproductive endocrinologists typically would also do additional surgeries if they want to, and, after their training, surgeries like, Mullerian anomalies that can be treated via surgery. For example, incision of uterine septums is something that we can do. In the past, historically, they used to do all the really intensive neovagina surgeries and things like that, which we very rarely do nowadays, but some still do them. They do, obviously, reproductive endocrinologists can do myomectomies as well, too. And we do a lot of hysteroscopies as well, too. So anything that can affect, the way I describe it is anything that affects the endocrine system that can result in reproductive issues can be managed by a reproductive endocrinologist. Infertility is managed by a reproductive endocrinologist, and then there's some reproductive surgeries that are managed by reproductive endocrinologists. Not to mention, like, fertility preservation, all those other things that are under the purview of reproductive endocrinology. So I think that sort of like sums it up in a nutshell what it is that we can do. Yeah.
So
in the
lots and
field.
lots of expertise and training there. So
That's right.
you guys are definitely a wealth of knowledge. So that's awesome. And we definitely do need more reproductive endocrinologists in these
We do.
rural areas, like where I practice, for
That's right.
example. So
That's right. That's
it's
right.
great that a lot of you are moving towards telemedicine and kind of bringing that much needed information to that population.
Absolutely. Absolutely. I think, obviously it's not always the first choice for patients to do telemedicine, but I see it as a way to just improve access, right? Because waiting 6 months, to see a reproductive endocrinologist and somebody who is already of advanced maternal age is not the right thing for that patient. You want to get in right away because we want to try to get things going quicker for those patients. And some of the pathways that some of us are thinking about developing is how to improve access to care. That is, having those initial consultations be via telemedicine is one way to do that, because it's about information gathering and then scheduling the patients for the testing that they need to do before moving towards treatment. So there are many pathways that are being investigated at this point in time to try to improve access, especially for those patients in rural areas.
That's great. Great. Definitely beneficial for our patients here in Pine Bluff. So
Of
lots of
absolutely.
good stuff. So I want to know, for the patients that are here locally, some of our patients, how do they get an appointment with you? How do they get in to see you if they're looking to see you?
Yeah, so I practice out of Pleasant Grove in Utah. That's where my practice is located. But at this time, because I was mentioning to you, I am doing sort of like a 75 to 80% telehealth because I live physically in Prosper. But then I can go over there to do the procedures that are needed for my patients. But helping to facilitate access to care is the goal here. And, the telemedicine has just been great in terms of doing that. So if patients want to see me for a telemedicine consultation, what they have to do is essentially just, I gave you the link to our website. Just call the office at Pleasant Grove there. they will be set up with a new patient coordinator. And if they want to see me, they can specifically ask for me. They're pretty good at the clinic in trying to ensure that, get the insurance information of the patients, letting the patients know ahead of time whether they're in network or out of network with us, and letting them know the cost of that visit. So I think that's the first thing to do, is just call the clinic in Pleasant Grove and request for a consultation with me. And because I offer telehealth, I can easily get patients in within the next 2 weeks.
Oh, that's awesome. That's
Because
awesome.
that's pretty much what I'm doing most of my time, is a telemedicine consultation, and I can get patients in pretty quickly.
Yeah. I mean, as a referring physician, that is absolutely amazing, because I've seen patients wait for months to see a specialist, a reproductive endocrinologist. I think in Arkansas, in our area, certainly, there's definitely a wait list for patients to be seen. So 2 weeks is amazing.
Absolutely, absolutely. So the patients can get in to see me, and then, but then the question is, with the testing, how do they, facilitate that? So, if patients are coming from out of town, it's something that we can work with them to make it easy for them to facilitate the evaluation and treatment. But it certainly has been very helpful for patients in Utah who essentially just want to get in right away and then start the treatment. Like, I've been, lucky that I've actually gotten some cancer patients into my schedule pretty quickly, because if they're about to start chemotherapy, we got to get them in very quickly, do their fertility preservation so as not to delay their cancer treatment. And that's something that we can offer, is that initial telehealth visit to talk about what the process is, and then get them in for testing and then start treatment. So I think it's, it helps with pathways to improve access for patients.
Yeah, this is awesome. Just kind of going back to what you were talking about, I just thought of a question here. So how young is too young, or is there an age that's too young for a patient to seek infertility or fertility preservation? Just really thinking about maybe a young cancer patient. What age is there an age limit of who can see a reproductive endocrinologist?
Great question. So a young cancer patient who is premenarchal, has not started their period yet. The treatment that's available for them is ovarian tissue cryopreservation. That is where they actually have to go through a procedure, usually via laparoscopy, to remove an ovary and then essentially cut out the ovarian cortex and freeze that. So that is the treatment of choice in premenarchal girls who have not started their period, who have to undergo some sort of gonadotoxic treatment. That is the recommended fertility preservation method for those girls. Postmenarchal girls, it's still oocyte cryopreservation. That is the egg cryopreservation. So they will have to go through the stimulation and have those eggs be retrieved. Now, if they're not a candidate for oocyte cryopreservation, which I can't really think of, at that stage, that's probably still the best thing for them to do. But an ovarian tissue cryopreservation can be offered at that point in time if they're not a good candidate for oocyte cryopreservation. And then, for women who are married and want, to create embryos, because we can more accurately predict the chances of an embryo becoming a baby, then embryo cryopreservation is an option at that point in time. And I usually always have to go through the risks, the pros and cons of doing egg cryopreservation versus embryo cryopreservation in, married couples. So those are the options available for fertility preservation. So to answer your question, there's not too young, essentially. It's something that's available even for premenarchal girls in terms of ovarian tissue cryopreservation.
That's great. And that knowledge hopefully will help some of our audience who had that question, because we talked about, kind of both extremes of age, if you will, and how a reproductive endocrinologist can assist.
Right. And, I would like to see ovarian tissue cryopreservation occur more and more. A lot of the times these are typically done in a lot of academic institutions. And, we're still looking at the best ways to preserve this ovarian tissue, even though we're seeing that the techniques that we use now for egg cryopreservation are just as good for the ovarian tissue cryopreservation as well, too. But I'd like to see more and more of that be offered. But I don't think at this point in time, we don't have a lot of long-term data in terms of what's going on with tissue that has come back that has been used after they've been frozen. There's a physician in I think in Missouri who has probably the biggest data set that I know of in the United States about ovarian tissue cryopreservation and use of those grafts later on in life for, essentially for patients who have gone through early menopause because of their cancer treatment, then come back and use that ovarian tissue just to support them so that they don't go through menopause indefinitely. And then, or sometimes they use it as well to try to get pregnant. So it's very, very interesting what's going on out there with the ovarian tissue cryopreservation, but it would be something that I would be interested in seeing more data and see more clinics offer that to patients.
Okay, that's great. And just kind of a question. I know, there are a lot of patients who don't have, maybe they don't have a partner yet, but they're starting to kind of think about preserving their fertility. What are some of the options that they have, and at what age should they really start implementing those?
Yes, I think, we don't have an age that we say you absolutely need to do this, like, egg cryopreservation or planned oocyte cryopreservation. But certainly we know that the younger a woman is, the better her chances of using those eggs to accomplish a pregnancy and a live birth in the future. So, I think right now, some of the limited studies that we have, a couple of hundred patients demonstrate that, women under the age of 35, if they come in, do an egg cryopreservation cycle and freeze 14 mature eggs, that they have a 70% chance of having one live birth out of that in the future. So what I typically just tell patients is that we are still gathering, studies, because this is a newer technology. Not a lot of people have come back to use the eggs that are frozen, but the limited data we have supports that the younger you are, when you freeze those eggs, the less eggs you need to freeze to accomplish a pregnancy in the future. And certainly the higher the chances of success as a result of that. So wherever women are, when they come to see me, I just counsel them based on their age and where they are and what we think would be a reasonable number of eggs to freeze to give reasonable chances of pregnancy. There's a calculator that's available that was based on simulated data that was, put together by a group of physicians at Brigham and Women's Hospital that I also use sometimes for counseling patients. But those are the resources that we use when we're talking to patients. Now, I think that it becomes a little bit trickier when women are over the age of 40 to really recommend egg cryopreservation, just because the numbers are so small. The studies we have, the numbers are so small for women in that age group, and the success rates are much lower at that point in time per egg. So women over the age of 40, it becomes really tricky to, counsel that egg freezing is the best thing to do at that point in time. That's why the younger they are, the better.
Yeah. So that's definitely the highlight that I'm getting from what you're saying, is that how patients can really help, the reproductive endocrinologist, is to bring up that conversation at the very least with their gynecologist.
That's right.
I try to kind of have that conversation with my patients when I see them, even for their annual visits. What are your plans, even when they're not actively trying to conceive, because I do find that a lot of patients come in down the road and they haven't had that conversation, and they didn't even know that they should have been having that conversation at a younger
That's right.
age.
That's right. That's pretty common actually for patients not to have heard that, not to have been questioned that and not to have talked about their reproductive plans. But I think, things are better now than they were 10 years ago in terms of information dissemination. But I think there's also the capacity for wrong information to be out there as well too. And, the healthcare providers are, we're the ones that can guide them in terms of making the right decisions about their reproductive plans and goals. And it is such an important topic to discuss. And, it's the thing that brings me joy every day, taking care of patients and helping them in that journey towards parenthood, just because of how emotional it is, and how it's so important to all of our patients. It's so important. And I'm glad that a lot of our colleagues and the gynecologists are talking to patients about this very important topic.
That's awesome.
Yeah.
Are there any resources that you would recommend to patients who are interested in fertility preservation, or just infertility? Any resources that you would recommend?
Yes, I mean, if you go to the American Society for Reproductive Medicine, the website, there's some patient education documents that they have. So they obviously have the part that's for the OBGYNs and the reproductive endocrinologists, so the scientific papers and all of that. But then they have the educational documents as well too. So patients can find out about pretty much any topic that they want to find out about, what to expect for the initial fertility consultation, fertility preservation, just like the really basic information about what's available out there in terms of the education on these different topics. So I encourage patients to go on it's www.asrm.org and look at that patient information. And there's lots of documents there, and they can select what they want and read up about it even before they see their reproductive endocrinologist or gynecologist.
Yeah, so there you have it. I have a lot of patients who like to do their own research. So
Yeah.
ASRM is definitely a credible source for you to do
Absolutely.
your own
ASRM is a
research.
credible source, and I don't think I'd recommend anything else besides that. I mean, for us doctors, we can say, okay, sure, we can go to UpToDate, we can go to PubMed and do a literature search and really get the information that we need. But for that basic information, just to know what's available, ASRM is the way to go for that patient education. I think that's where they will get the most credible information.
Awesome, awesome.
I'd like to know what your patients feel about it, the feedback that you receive on it. Yeah.
Yeah, and certainly, I hope this is just the beginning of the conversation. I know that, we're probably going to have a lot more questions and things like that. So I would love to have you back for our expert series to answer a few more
Absolutely.
questions, maybe some from our
Absolutely.
patient. Yeah.
Absolutely. It'd be my pleasure to do that.
Yeah.